Good evening, everybody. My name is Kim Wilde. I'm a current lecturer in podiatry at the University of Salford. I've been teaching now for 2 years, but my background is that I've been a podiatrist for 24 years. So I spent most of my career working within the NHS and probably about 18 years of that within the high-risk foot and treating patients with diabetic foot ulcers. So this evening, we're going to be talking a little bit about strengthening patient concordance and autonomy in the treatment of diabetic foot ulcers. So initially, we're going to talk a little bit around what does it currently look like, what is the incidence of diabetic foot ulcers in the UK, and then we're going to look at the factors around, why patients don't concord as well as we'd like, and then we're going to talk about some ways and communication styles of how we can strengthen that sort of shared decision making with patients. So if anybody has got any questions, please add them to the Q&A button and we will answer them at the end of the webinar. Okay, so a little bit of around diabetic foot ulcers in the UK. So the lifetime risk of developing a diabetic foot ulcer is between 19 and 34%. One of the issues that we do have is recurrence is very common after initial healing. So approximately 40% of our patients will have another ulcer within a year after ulcer healing, and almost 60% within 3 years and 65% within 5 years. So we've got, a real challenge there with patients engaging in looking after their feet post healing. And treating foot ulcers accounts for approximately 1% of the total NHS budget, which is quite a lot of money. The issue that we've got around the future is that further to the projected 5.5 million adults who could be living with diabetes by 2030, an extra 17 million people could also be at increased risk of developing type 2 diabetes by 2030. So we can see, that the incidence of diabetes is going up. So of course that will have impacts on foot disease in the future. So let's have a little look around mortality rate for people with diabetic foot ulcers. So this is a research study that was done by Stedman et al. In 2023, and the reference will be at the end if you'd like to read it. So the mortality rate for people with diabetic foot ulcers is 231 deaths per 1,000 person years, compared with 182 deaths per 1,000 person years in people with diabetes without a foot ulcer. So the proportion of individuals with foot complication increases with the duration of diabetes, which is what we'd expect. And the prevalence of a diabetic foot complication was greatest at between 9 and 13 years after diagnosis. The percentage of people with type 2 diabetes and a foot complication that died for any given year was 3 to 4 times higher than those without a foot complication. So we can see that, having a foot ulcer, obviously puts the patients at greater risk of mortality. One of the things that I was involved in when I worked with the NHS was the National Diabetic Foot Audit. So this has been occurring since July 2014. What we do with the diabetic foot audit is that when a patient presents with a new diabetic foot ulcer, we record it, and then we go back after 12 weeks and record what's happened to the patient. Do they still currently have the foot ulcer? Has the foot ulcer healed, or has the patient passed away? So the most recent data that we've got for this was between 2018 and 2023. So there was 122,030 foot ulcers were recorded. Bearing in mind that this is only as good as what the staff that work in the NHS actually record. So there would probably be a lot of missing patients that are not actually in this audit that just haven't been recorded by the staff. But one of the things that I really wanted to point out was that nationally, there's been an overall decline in the mean percentage of people alive and ulcer-free at 12 weeks after first expert assessment. So that has gone from 46% in 2018 to 2019 to 42% in 2022 to 23. So the key things sort of take-home messages from the National Diabetic Foot Audit that is important is that early expert assessment of all new foot ulcers is very, very important. The audit has shown that faster referral to specialist foot care service leads to fewer severe ulcers and greater chance of being alive and ulcer-free at 12 weeks. There's still a massive variation of care offered throughout the UK. So what may be offered in Greater Manchester would be different in the London area, in Scotland, etc. And they also found that patients who self-refer have improved outcomes. So it'd be interesting to know, why are these patients self-referring? What extra care have they been given? What extra education advice have they been given to ensure that they are self-referring and making sure that they have improved outcomes? So that's a possible research question for the future. So thinking about your own practice, have you ever worked really hard on creating a wound management plan, and as the patient leaves the room, you know that they're not going to follow it, and experience the frustration when a patient hasn't followed through with what you agreed? I think everybody that's listening this evening can agree that this has happened within their practice. So why does this happen? So what we're going to do is we're going to look at why this happens. So this is our current situation from research into patient perceptions of diabetic foot ulcers. So one of the things these are some of the key things that came out of research papers that I looked at, was that patients lack awareness of what a diabetic foot ulcer looks like. So if they've not had an ulcer before, they don't know what it looks like, so they don't know that they need to seek advice and help. Participants' beliefs regarding diabetic foot ulcer causation often conflicted with conventional medical understanding of this condition. There was some evidence that individuals who had no prior experience of ulceration viewed diabetic foot ulcers as an acute condition that would heal quickly. So almost like, if I've got a cut, I'll put a plaster on it and it will heal. Many participants were either unaware of or unconcerned about their risk of diabetes-related foot problems. So the fact that they're unaware of this or unconcerned obviously means that there's an education gap there. Many individuals had limited perceived control over diabetic foot ulcers, particularly those with previous or current ulcers, and they felt that little could be done to prevent diabetic foot ulcer occurrence. So again, why is this? Why do they feel like they've got a limited control over this? Again, do we need to be educating them more around prevention? Another key things that we need to bear in mind from research is that many were unaware or had limited knowledge of the role diabetes plays in diabetic foot ulcer etiology, and that was irrespective of their ulceration status. So they don't know how to link their diabetes with ulceration. Some only received a diagnosis of diabetes on presenting with an ulcer. So obviously they presented to the GP with an ulcer, and then they then got the diagnosis of diabetes, while others did not become aware of the relationship between diabetes and foot problems until seeking treatment for ulceration. So again, they didn't realise that the two were linked until they went to see a medical health professional and obviously gained that knowledge. So participants in a lot of the papers, especially those with a history of ulceration, expressed uncertainty or had a negative outlook regarding the future. So we can see there that that's affecting, the patient's resilience and motivation, whereas those with previous or active ulcers viewed healing as a prolonged or indefinite process. So again, these patients have experienced long periods of having a chronic ulcer, months or even years. And some believe that diabetic foot ulcer and amputation only occurred in acute cases or instances of poor hygiene, and were critical of individuals who neglected themselves to such an extent. A lot of the people in the research, it was apparent that they did not consider cuts or sores on the foot to be a cause for concern, and they believed that they would heal easily without medical intervention. There's probably a number of people again on the call, where patients have been self-managing and then they come to see you, and obviously the foot is in quite a poor state. And those with a history of ulceration acknowledged that they had failed to grasp potential seriousness of diabetic foot ulcers before it was too late. So when we look at this, you can see that there's a lot of lack of understanding around diabetes and how that links to foot ulceration. And, we really do need to improve this. One of the other things that we need to also consider is diabetes and mental health. So approximately 1/3 to over 40% of people with diabetes experience psychological and or social problems that can interfere with their ability to self-manage their diabetes. Again, we need to be ensuring that any mental health problems are treated and social needs are met, because this will be valuable in improving the individual's health. And when a patient has a number of chronic conditions, quality of life can be reduced. This can really also impact on a patient's resilience. And again, research has shown that an estimated 30% of patients with chronic wounds suffer from anxiety and depression, and the risk of depression increases with the duration of the wound. Patients with chronic wounds, again, they may experience reduced autonomy, anxiety, or depression, and this can inhibit their compliance or decision making. One of the things that NICE Guidelines does recommend is that the multidisciplinary foot care service should have access to rehabilitation services, plastic surgery, and also psychological services. And although in my practice we didn't have psychological services, I did become more aware as I sort of gained experience that these are key questions that I need to be asking my patients, and I need to know how to refer a patient to psychological services. But again, do we get trained on having those difficult conversations with patients? Because mental health, it can be quite a difficult subject to broach. So stress. So the available evidence suggests that a person's perception of their wounds contributes to healing, and wound healing can be negatively impacted by stress. So, if our patients are stressed, they've got, a long-standing chronic wound, it can really impair the wound healing. And again, we need to really be signposting these patients to mental health services. Okay, so we're going to move on a little bit to around patient feelings on diabetic foot ulcers. So Wounds International Best Practice Statement, Optimising Patient Involvement in Wound Management, conducted some qualitative interviews with patients with diabetic foot ulcers. And I just really wanted to just add some of these comments because I felt it was really quite interesting to see how patients actually feel that I've got a diabetic foot ulcer. So we'll just bring a couple of them into the conversation now. So bad experiences with care can make you feel reluctant to go back. Every day is a struggle. You want to feel listened to and more in control. It makes such a difference to be treated as a human being, not just a number. I get so fed up with it. I feel so low. It stops you living your life. It takes your freedom and limits what you can do. So you can see that there's a massive sort of lack of motivation. People are feeling extremely low when they've got a diabetic foot ulcer. Some patients are feeling like they're not being listened to. One patient said you have to push and push. It's hard to get the support you need. So there's lots of conflicting issues there around how patients feel about having a diabetic foot ulcer. Um, so we're going to move a little bit now around thinking about kind of shared decision making, autonomy. Um, what should we class it as? Should we class it as compliance, concordance, or adherence? So I feel like we're moving away from compliance. So compliance really does have undertones implying that health professionals know best and assumes that patients should obey instructions they are given. I quite like concordance because it does really refer to the alignment or shared understanding between a patient and their healthcare provider. It's really looking at that patient healthcare professional relationship. It influences patient satisfaction, communication, and overall healthcare experience. The World Health Organization likes the term adherence. So adherence refers to the extent to which a person's behaviour corresponds with agreed recommendations from the healthcare provider. One of the things that we really need to be moving away from is the traditional style of communication. Um, and, we all get taught at university, how we should treat diabetic foot ulcers, how we should offload them, what the gold standard of care is. But the traditional healthcare provider style is often very highly directive, and it's sometimes restricted to demanding adherence to a list of behaviours with little input from patients. That traditional healthcare provider style, it is very much, I'm the expert and I'm giving you the advice. Two of the main components of this traditional style are information exchange and persuasion. But the trouble is, when we're trying to persuade patients to do what we think is best, this can then lead to resistance. And really, we do need to be moving away from that and really improving our communication skills so that we get better outcomes for patients. So one of the things that we need to be thinking about is shared decision making. So this is a process where us as clinicians and patients, we share the best available evidence when making healthcare decisions and supporting informed preferences and promoting individual autonomy. So patient autonomy and shared decision making really sit hand in hand. Um, Shared decision making is a key component of NHS England's approach to personalised care, and it really does involve a collaborative process where healthcare professionals and patients really do work together to make decisions about the patient's treatment and care. So this process ensures that patients really are fully informed about their options and can make choices that actually align with their personal values, preferences, and circumstances. And unfortunately, that may mean that that patient doesn't actually sit in that gold standard treatment box, that actually what their personal values and preferences are may differ from that. The proper practice of shared decision making recognises that clinicians we play a critical role in educating patients about their treatment alternatives and really helping patients align their choices with their values. So patient autonomy. So this really does refer to the ability to act intentionally with understanding and to enable a patient to remain autonomous. And I've highlighted that there. Communication between the practitioner and patient really is key. And I think this is where, we really need to work on changing our communication skills away from that traditional way of communicating with patients. The right of patients to make decisions about their medical care without experiencing undue influence from healthcare providers. And like I said earlier, not every patient will fit in that traditional treatment box. And, we shouldn't influence their choice of what is important to them, but actually, communicate the different types of treatments and align that with what's important to the patient. So I've had a little look at recent research into barriers and enablers to diabetic foot ulceration and self-management. So, what were the barriers and enablers for patients to be involved in managing their diabetic foot ulcer? So again, this was a qualitative interview study, and it was conducted in 2023. It was actually a study in Singapore. Um, and they reported that more personalised consultations encourage patients to take an active role in foot self-care and also sort of involvement in wound care dressings. Patients were very keen to see the same like wound nurse or podiatrist, not only for wound care, but also to get personalised support. And also, it sort of allows individualized motivation to live well with their chronic foot conditions. So they've obviously gained a really good relationship with the healthcare professional and felt quite confident and motivated. So there's three themes that were found from this research were individual perceptions, healthcare system influences, and relational and community social factors. So there were a number of barriers. So social stigma was a barrier. So patients felt a lot of social stigma if they had a wound that was odorous or, quite a bulky dressing wound and had to wear a dressing sandal or a shoe. Enabler was family support. So if they had family support, that enabled them to feel more motivated about being involved in their care. Again, if they had community social support, that was an enabler. Again, poor patient practitioner communication was a barrier. Financial concerns, again, were a barrier. So there was financial concerns around care and also around the fact that they may not be able to work. And again, a barrier was lack of control over ulceration and treatment. So obviously some of these patients felt like that they weren't being involved with their treatment. Disease fatigue, they were just fatigued with the diabetes, with having the wound. It just got too much to them. Perceived low threat of consequences, the consequences of having the wound, the threat is generally to their life. But motivation through personalised care was an enabler. So that's really, really positive, and I think we need to pull that out of there. That the fact that if the patients did have personalised care, that really motivated them to be more involved with their wound care. So I'm going to talk a little bit about some research that I carried out in between 2018 and 2020. I spent some time developing a wound pathway within a trust within the Northwest that I worked for. And as part of that pathway, I actually conducted some research. And again, similar research to what I've just talked about, I actually conducted qualitative interviews, and that was with 12 patients. There was a number of patients that had diabetic foot ulcers. There also was patients with leg ulcers and dehisced wounds. There was a range of patients. Some of them lived alone, some of them had a carer, some of them were housebound. And it was quite interesting because when I look at that 2023 research that I've just talked about, a lot of the key themes were very, very similar. So I did a thematic analysis of the interviews. I spent quite a long time interviewing the patients. I talked to them about, did they understand what their wound was? What did they feel about their wound? How did it impact their life? Who helped them with wound care? How did they feel about doing their own wound care? And the key themes that I pulled out were they ranged from wound type and characteristics. So obviously if a patient had a wound that was hard for them to get to, that really stopped them from being involved. Also, if they had a wound that was oozing a lot or was quite odorous, some of them felt that they didn't want to be involved in that. They didn't like touching it or going near the wound. Some of the perceptions of self-management I got from there was support from healthcare providers was a big one. If they got really good personalised care and really good support from the healthcare provider, that again motivated them to want to be involved with the wound care. Wound duration and complications was a barrier. So again, patients became less motivated the longer they had the wound. Some of them talked around infection and pain, and that really made them feel that they didn't want to be involved in the wound. They were scared of it getting infected. It was too painful for them to get involved in the wound care. Support from family and friends was a massive enabler. Some of the patients weren't able to do the wound care themselves, but their carer, wife, husband, etc., had been educated on how to do the wound dressing and had supported that person to enable them to be more involved in wound care. Some of the other things were the fact that, patients didn't really want to be tied to going to clinics 2, 3, 4 times a week. They wanted the ability to have some freedom and have some life. One patient wanted to be able to go to his caravan for a few days. So the fact that he was able to be, his wife to be trained on how to do his wound dressing really helped a lot. One of the real big barriers that I found from this research, which actually surprised me at the time, was the fact that there was a number of patients that stated that their nurse or podiatrist didn't want them to be involved in self-management. And they weren't sure why. And I don't know whether that was the fact that they were worried that the patient would do something wrong and that they would cause the wound to deteriorate. And that's something that I'd like to look forward in the future, maybe do some research around staff's perceptions of patients self-managing wounds. And my summary from this research was that some of the participants really had a positive impression of being involved in their wound care, but there was still a number of patients that were reluctant to self-care, and those tended to be the ones that didn't have that social support and that had quite a number of complications related to their wound. So from this research, one of the things that I did was I went back and made some changes in practice. And what I wanted to do was to streamline the self-management process and look at how we can get patients to engage in their wound care. So what I did was I developed a working group, and that included patients. And I think that was a really key, important element in the fact that, I had patients on there that had diabetes. Some of them have had wounds. So I was able to really get a really personalised approach to the work that I was doing. The working group had podiatrists on there, it had nurses on there, I spent some time on clinics with different healthcare professionals that were involved in wound care to get their thoughts and feelings. I did a lot of training with staff. So I did some training around thinking differently. So really thinking differently about our patients and the way we engage them and the way we speak to them. We did training around patient activation. And one of the other key things we did training around was motivational interviewing. And I'll talk about these in the next few slides. We also developed patient information around wounds and wound care, and that included videos and leaflets that the staff could link the patients to, again to ensure that they when they went away, they had a leaflet to refer to, or they could go on YouTube and watch a video that would just remind them of how, one, they should be washing their hands, two, how they should be, using sterile gloves, and how they should be applying their wound dressings. Some of those videos are actually at the end of the presentation for you to look at your leisure. So let's talk a little bit about patient activation, because this, I think, is a really, really important tool on, how we can work with our patients. Patient activation describes an individual's knowledge, skills, and confidence for managing his or her health and healthcare. Patient activation measure is really recognised by NHS England. You can Google it, and the patient activation measure is freely available if you really did want to use that with your patients. Measuring patient activation is a way of understanding behavioural patterns relating to healthcare service utilisation, and patient activation can be improved through interventions such as health coaching, peer support, self-management education. So obviously some of the things that I developed within my wound care pathway really did help that education. So the patient activation measure is a 13-item questionnaire, so it generates a score between 0 and 100, which corresponds to an activation level between 1 and 4. It's an actual asset-based approach, so it puts the individuals in the driving seat by increasing their capability, and it supports people by giving them information they can understand and act on, and provides them with support that is tailored to their needs. So if we look at it a little bit more in detail, so there's 4 activation levels, and this resides along a continuum. So there's level 1. So this is where your patient is very overwhelmed and disengaged. So they don't feel in charge of their own health. Managing their own health is really, really overwhelming for them, and they have few problem-solving skills. So level 2, they're becoming aware, but they're still actually struggling. So they may lack basic knowledge about their condition, treatment, and options, and they have little experience or success with behaviour change. So level 3 is where they're actually taking action. So they've got the basic facts of their conditions and treatments, and they've got some experience in making behavioural changes. And level 4, and that's where we'd love all our patients to be, they're maintaining behaviours and pushing further. So they have the basic facts of their conditions, treatments, and they've got some experience, success in managing behavioural change, and they've got some confidence in handling limited aspects of their health. So in England, we've got more than 50 million people that have got a long-term condition, and this group tend to be heavy users of the health service, and they're accounting for at least 70% of all of the NHS spend, but they're likely to spend less than 1% of their time in contact with health professionals. So patient activation is a behavioural concept, and it relates to the degree to which patients understand their role in their healthcare and how competent they feel to fulfil that role. So if you've got a patient with low activation, they're going to need tailored support and care to build their confidence and capability to move them up to a higher level. So patients with higher activation may only need lighter support. So if you are actually measuring your patient activation level, you can then gauge exactly what treatment plan is correct for that patient going forward. So taking all that into consideration, I decided to look at how was I going to effectively create a long-lasting change in behaviour around wound care. What actions could I put in place to ensure that patients felt motivated and confident to engage in managing their wound? So one of the things I did is to look for a behaviour change model. So I came across a model called the COM-B model for behaviour change. And this model proposes that to engage in a behaviour, a person needs to have, one, the capability, two, the opportunity and motivation to perform that behaviour. And so all of these, so the capability, motivation, and opportunity are all interlinked with that behaviour change. So with the capability, so has the patient got the knowledge, the skills and the abilities to engage in that behaviour? And this capability compromises mental state, knowledge, skills and physical strength. If you think of in what we talked about earlier, when many patients were unaware or concerned about the risk of diabetes-related foot problems, and that's because they didn't have that knowledge and skills and that ability to engage in that behaviour. So opportunity, so this refers to external factors that make execution of a behaviour possible. So physical opportunity, opportunities provided by the environment, a social opportunity. So obviously care is being involved. Does the patient have the correct dressings, gloves, etc., to be able to do the dressing change? And motivation. So again, this is really important. So this refers to the internal processes that influence decision making and behaviour. So for example, to improve motivation, it is helpful to turn a desired behaviour from something they need to do to something they want to do by encouraging reflection of the benefits of performing that behaviour. So I looked at the COM-B model and I linked it into our wound care pathway and how we would motivate that behavior change. So when I looked at capability, I looked at the physical skills. So if the patient couldn't get down to the wound dressing, could we then look at bringing in carers to support that? Improve knowledge. So again, educating the patient around what is diabetes and how does that impact on the foot. And we also developed a competency assessment as well. So the staff could work through the competency assessment to ensure that the patient had the capacity to be able to change their wound care dressing. Motivation, so we looked at motivational interviewing for staff and utilising motivational interviewing skills to engage with the patient, so that really we were engaging with that patient's beliefs and expectations around their wound care. An opportunity, so making sure that we had that really good relationship with the healthcare professional, and also looking at, does the patient need social and physical support to be able to engage in their wound care? So again, thinking about, important to or important for. So this is another part of training that I actually looked at with the staff. And again, there's a video, the links beneath on this slide and also at the end of the slide. So changing the dynamic of the patient and clinician interaction. Instead of what can I do for you, what matters to you? Really sort of turning it around, what matters to the patient, being very open and honest, talking to them about the pros and cons of treatment so that they're well informed and taking on board their individual preferences. One of the best sort of training that I think I've ever been on was motivational interviewing. There's been a lot of motivational interviewing research into long-term conditions. There's quite a lot of been done in the diabetic foot in a prevention point of view, from preventing complications. There's a current study going on in Scotland, and they're looking at motivational interviewing for patients that have got current foot ulcers and how that will improve amputation rates. So that'll be interesting to see the results of that when that's completed. But what we really need to do is move away from spending your life explaining what your patient should, must, or need to do. So motivational interviewing, it's a style of communication that uses a guiding, reflective style to engage with your patient, clarifying their strengths and aspirations and utilising their own motivations for change, and promote that independence of decision making. So the essence of motivational interviewing is that it is the patient rather than the clinician who makes the argument for change. It's not a collection of techniques, but a way to guide the conversation, again, to activate, so thinking about patient activation, a person's own motivation and resources for change. And it's a way of having that conversation that helps to understand reasons, barriers to change, and support and adopt new behaviours, or even stopping unhelpful behaviours to prevent foot ulcers and motivate patients to be empowered to engage more in their care. And that's including self-management of the wound. I always think when patients come into a room, sometimes it's almost like they're giving me their foot and their wound, and we really need to move away from that, in that, you know, the patient has more ownership for their own care. So the concepts of motivational interviewing, so asking open questions, so we're exploring concerns, we're promoting collaboration and understanding the client's perspective. So generally our open-ended questions will begin with what, where and how. So an example is, instead of asking it, do you redress your wound daily? Tell me about how you look after your wound. So turning that into more of an open question. Affirmations, and that's to support strengths and convey respect. So affirmations are statements of what the client is doing well and what the behaviours or strengths they're exhibiting will help to bolster their self-efficiency. So again, I know it can be difficult managing your wound dressings, but you were doing a great job. So again, just giving them that positive message as well. Reflective listening, so that's to explore deeper, convey understanding, deflect discord, and elicit change talk. So reflections are statements reiterating what the patient is telling the healthcare professional in a way that shows the patient the clinician interprets their words. So an example of this would be, my feet are already numb and now I have an ulcer. So my work schedule doesn't allow me to follow a daily foot routine. I try my best to do my dressings, but sometimes I just can't be bothered. So how we would be reflective with that would be, so you do a pretty good job of doing your dressings, but at times it can be a problem. What do you think you could do to change this? So again, having that open question at the end so that the patient's thinking about what they can do to change. And summarize, so to organize discussion, to clarify motivation and provide contrast and focus the session and highlight change talk. So summaries really do differ from reflections in that they simply summarize what the patient tells the clinician. Summaries help patients to feel heard, and we're an important step to keep conversations moving forward while demonstrating active listening. So an example of this would be, today we talked about ways you may better remember to take care of your wound and what some of the barriers for you doing this are and ways of overcoming them. It looks like you have some good ideas on how to remember to change your dressings. We also talked about how you are concerned about your ulcer and the chance of getting another infection. So where does that leave you on changing your dressing every 2 days? So again, you know, it's leaving that change talk at the end for the patient to come up with their ideas of what they will do and how they can improve. So motivational interviewing is essentially, it's not argumentative or judgmental, an immediate outcome that provides note that an improvement in patient satisfaction, because we are really listening to patients and work with them on the goals that we've negotiated for them. I've just put on the next slide some these are some open-ended questions that you could utilise. These were developed by the Wounds International Group. So again, you know, seeking patients' views and understanding of their condition. Do you understand why you have a wound? What are you interested in learning about your wound? And identifying if the patient has any fears or concerns. So again, looking at, you know, where is that patient activation? So what worries you most about the wound? How does your wound affect your daily living activities? Establishing what is important to the patient, you know, what do they want to achieve in the long term? Is wound healing their main priority? For some patients, it may not be. And assessing patient willingness to be involved in their care. So what do you need to know? What can you do to help heal your wound? What are your living circumstances? And who else needs to be involved to help you manage? So I think my light bulb moment after I had my motivational interviewing was with a lady who had a chronic diabetic foot ulcer. She'd had it for over 12 months. She's a female lady, 54. She was currently working and she was just refusing offloading. And I'd pretty much gone in with the whole, you know, you need the gold standard, total contact cast. I didn't actively listen to what her wants and needs. So she was a lady who was working. The only offloading that she would accept would be a chairside insole with a little bit of padding because she wanted to still be able to wear her shoes. And I used some of the motivational interviewing techniques. I think one of the ones that I really improved on was listening and listening to what was important to the patient. And one of the things I picked up was that this lady really wanted to go to New Zealand to visit a family member and she wanted to go this year. So I linked into that because that was her motivation. And I talked about the fact that, did she want to be ulcer free for this trip? And she really, really did. And that was her motivation. She said, Kim, can I get myself without an ulcer? I want to be able to go on holiday, not worry, just enjoy myself. And we negotiated the offloading. Then I talked about the fact that, okay, a walking cast may not be what's right for her. We managed to put her in a slipper cast. And even though she did have a cast sandal, she was willing to try it, short term to see if there was an improvement, just because her motivation really was to go on this holiday. And within 2 weeks, the wound had healed, and she was just really over the moon. And so it was just for me, just taking that time to really listen to what was important to that patient and not going in with just that traditional style of, right, you need to do this, 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 and this. So some of the other things that I think we can utilize to strengthen patient concordance and autonomy is, diabetic foot screening. I've done a lot of work with practice nurses around diabetic foot screening. And, we really need to look at, what should we be telling those patients, just to prevent them from having diabetic foot ulcers, within 9, 10, 12, 13 years. After their initial diagnosis. And a lot of the practice nurses said, that there was a lack of good training around diabetic foot screening. And obviously, they really are limited with time. Again, structured education, this is mentioned a lot in the NICE guidelines. But I know it does vary from area to area, but, it's really important that patient has really good structured education around, what a foot ulcer looks like, what their foot risk is, and if they are low risk, that they can move to moderate risk, and just making sure that the patient is aware of that. Again, technology is really important, and we're moving forward a lot with technology. We used technology in my last trust, and we used a text messaging service to again, motivate patients to be more engaging in looking after their foot health. There's a video again at the end of this presentation that you can look at, and that was really positive. And again, thinking about psychological interventions, do we need to be more actively thinking about that? If the patient has mental health issues, again, that will really, really reduce their activation, and again, will impact on their wound healing, but also will impact in their ability to want to be involved in their wound care. So we'll talk a little bit, just briefly, just before we end the presentation, around what dressing for what patient. So when we're thinking about wound care, we need to be focused on individuals, which means using the right product for the right patient in the right way. And again, here's a few little comments from selecting the most appropriate products to facilitate a shared care approach. Again, this is from Wounds International 2020. And these are some of the key things that patients wanted from a dressing. They wanted it to be comfortable, not too sticky. It needs to deal with odor. There's quite a number of things. So again, it's listening to the patient. What do they want from their wound dressing? Again, if it's right for the patient, they're more likely to engage in their, supporting their self-management, or even being more engaging in their wound care. Is it that you need an autolytic debridement dressing, so that in between sharp debridement, that wound, particularly if it's very sloughy, is getting the treatment that it needs? If the patient is self-managing, is it the fact that you want a dressing that will last up to a week, so that the patient doesn't have to be changing it too often? The patient's got an ischemic leg or wound, do we need to have a dressing with a silicone border, so that we know they're not going to be doing any peri-wound damage on removal? And also, we need to be thinking about, is the patient quite happy with their hand washing? Have they got dressing packs for self-managing their wound? Have they got, good information about self-management, and a leaflet to support the dressing process? So in summary, so patient autonomy is essential in managing diabetic foot ulcers. So it involves empowering patients to take an active role in their care and making informed decisions. I think the thing that's really important is education and communication are really, really key. and making sure that we're tailoring our treatment plans to individual patient needs and preferences. And that encourages adherence, and it really does improve outcomes. And setting personalised goals and involving patients in decision making fosters a sense of ownership over their health. One of the key things that I really would recommend is trying to go and do some motivational interview training. It really, really did change my communication skills with patients, and I did really find that I got a lot better outcomes with patients. So even if you take that as a take-home message, to book on some of that training, that'd be amazing. So here's some useful videos for you to look at. So there's one there around patient activation, motivational interviewing, thinking differently. I've also put 2 videos that we developed around wound care and self-management, and they really are quite useful and interesting to sort of reinforce some of the key messages that I put across on this training today. And are there any questions? And also the references are at the end of the presentation. Hi everybody, thank you for listening to the presentation. Does anybody have any questions? I'm just going to go to the question and answer. So what is the clinical recommendation for performing routine superficial wound culture? So realistically, superficial wound cultures are probably not very helpful. You would find that the majority of wounds are going to be colonized. Obviously we have bacteria flora on our skin anyway. So we're moving more towards tissue sampling now, or if you were going to do a wound swab, having a deeper wound swab would be more beneficial, or even taking a sample of pus would be helpful. But for me, if the wound's superficial, I'd be looking for the clinical signs of infection and prescribing from that. It may not always be useful doing a superficial wound culture. How do I best manage patient self-care and emotions? Again, for me, active listening is massive. So with patients, I really need to know how they're feeling, what motivates them. For instance, one of my patients who had a wound, he was waiting for vascular surgery, had a really odorous wound. And just by active listening and using the motivational interviewing techniques, for him, the key thing was the odor. The only thing that he really enjoyed in life, because he was disabled, was going to his caravan at the weekend. And the odor was making it quite difficult for him. So again, listen to that, change the treatment dressing regime to a dressing that really managed the odor, which really improved his quality of life. So again, it's not always looking at something that's very big. Motivation for some patients could be quite small. They might be very low with the patient activation. So it may just be small baby steps with changes to them, and so that you can improve that activation. So it's just about utilising your communication skills with the patient. Some patients don't want to dress their ulcer, neither go to the nurse. What do you say to them? So for me, I need to get an understanding of why they don't want to dress their ulcer or go to the nurse. So again, do they have a good understanding of what their wound is? Do they have a good understanding of the complications of their wound? A lot of the time it is a lack of understanding. So the patients don't understand about infection, they don't understand around the importance of wound debridement. So for me, I take a little bit of time understanding what that patient's knowledge is around their wound, and maybe look at what their fears are around having someone dress their wound, and work with that around, what can I do to motivate them to engage better. Is motivational interviewing something you've used for patients with diabetic foot ulcers? Yes. Once I actually did the training, that is the only kind of sort of communication techniques that I use with patients. I think one of the hardest things that I found to accept initially was that there was different levels of motivation, and for some patients, it may be that they would only really want a chairside insole to offload a wound.
and they were nowhere near sort of gold standard care. But I had to accept that as a clinician, because obviously they had capacity to make that decision, and I gave them all the pros and cons of treatments. So again, it's really having to think about the patient's preference over me being adamant that they needed to have gold standard care. And it's about meeting in the middle with some patients who just really weren't motivated enough at that period of time. And I think, you can work on that with patients, and you can increase their activation. Particularly if you're seeing that patient regularly and you're having really good communication skills with them, and they get to know you and trust you. Again, that can increase their activation, and can allow them to be more motivated to be involved more in their care. How can you best manage the patient's circle and emotions? I've done that. I have always encouraged patients to be active in their self-management. One of the key things I always made sure that I did was make sure that the patient's got capacity, because again, that's really important. So you can do a basic capacity assessment with a patient. I always made sure that the patient had all of the dressings, that they had really key advice around hand washing, ensuring that, they were using gloves. So I made sure the patients had dressing packs. I always backed it up with a self-management leaflet, and also the video that you're going to get sent as well, to just support them with the self-management. And, a lot of patients don't want to be coming for an appointment 3-4 times a week. There are, small percentages that do. But, I found my patients were getting younger. I had a lot of middle-aged patients who were working, and they couldn't take time off work to come to a dressing appointment. And, again, for me, it's about empowering the patient. So one of the things around motivational interviewing is it's their wound, and a lot of patients would come into the clinic, and it would be almost like, right, Kim, there's my foot, there's my wound. So again, for me, it's empowering that patient. It's their wound. They have to make the decisions. I will support them with the advice, the treatment options, but realistically, they need to have that ownership for their wound. What do you think are the main barriers to supporting patient autonomy in practice? I think time's massive. I think probably everyone on the webinar will agree that, we don't have a massive amount of time with patients. So, having the ability to have a really good session around listening to them, doing that shared decision making, that can be very, very difficult. And particularly if you're in a busy clinic and you've got a lot of pressures. And again, sometimes if you've not got that MDT team as well, so if you've got your patient's got really high blood sugar levels, and that the wound is never going to heal because of that, if you've not got someone that can support you with discussion around that, like a doctor or a nurse, again, it may be that you again have to refer to the diabetic nurse. So again, it can be a bit disjointed, the care. And also, financially as well, unfortunately, it's a little bit of a postcode lottery around the country around, how much time you get with patients, if structured education's available. Also, if there's, like patient-assisted exercise therapy for patients, how long your patient waits to see a vascular surgeon, and they can all really massively impact on, giving the patient what they really need, and the support that they need to sort of improve their health. See if there's any other ones. I think we've got the videos there. Is there any other questions? I think I've managed to cover everything. But really try and get yourself booked on some motivational interviewing. It is really, really a massive way of learning and how to communicate with patients. I just found it really, really valuable. But thank you for attending this evening. Obviously, if there was any questions, I'm sure that you can email Flan and they can pass them on to me and I can answer them. Okay, don't think there's any more questions. So thank you. Thank you so much for joining us this evening.